respected chairpersons, senior colleagues, and dear friends. The indications for mechanical circulatory support in CHIP, actually two scenarios. A, high-risk patient in the acute setting with cardiogenic shock. B, prophylactically in elective PCI with complex anatomy plus or minus severe LV dysfunction. That is the classical CHIP scenario. We will discuss that first. So CHIP subset without cardiogenic shock, they are at high risk of peri-procedural hemodynamic instability and death. Currently, there is no universal definition for CHIP. By the morning discussion, you will be knowing that high-risk anatomy, distal left main lesions, complex coronary lesions, especially high-risk CTOs with LV dysfunctions, lesions requiring atherectomy, or impaired LV function with low threshold to develop pulmonary edema. As Dr. Ajit said, it is not only the complex anatomy, but also the hemodynamic factors of the patient, as well as the comorbidities like heart failure, diabetes, age, renal dysfunction. Why MCS? Although there are no definitive evidence supporting the benefits, use of MCS in this setting is often regarded as a safety net against the possibility of hemodynamic instability or prolonged hypoxemia. Three most popular devices: IABP, percutaneous assist devices including impeller and tandem heart, VA ECMO. And when in the scenario of stable elective patients to support PCI, tandem heart or ECMO is rarely used prophylactically, either IABP or impeller. Let me discuss about various clinical scenarios for MCS use during CHIP. The first and foremost, unprotected distal left main with severe CAD with a syntax score more than 22. A high proportion of these patients have associated multivessel disease and LV dysfunction. And when syntax score is more than 32, it's a classical surgical case, but sometimes PC is considered because of surgical contraindication or refusal due to clinical and anatomical conditions. The second subset is complex CTO. There are two situations, ejection fraction less than 35. So this is the classical situation where you suggest MCS, especially when needing a retrograde approach in the ischemic chance of a donor vessel or a CTA PCI with rotablation, hemodynamic instability, you expect slow flow phenomenon. So when the ejection fraction is more than 35% in CTO, it's not an indication for MCS, but it may be useful in the following situations. When the patient is having a double CTO and you require a retrograde approach through the last remaining patent conduit, or in case of a significant hemodynamic instability that prevented completing the PCA in the first attempt. The first attempt you could not do the procedure because of the hemodynamic instability. In second case, you can select MCS as a support. Third important situation is the last remaining vessel with occlusion of the native or bypass supplies remaining the two coronary arteries, two coronary territories. So here the CHIP is important because a large territory of myocardium is involved and you can expect anticipate hemodynamic problems. For example, transient interruption of coronary blood flow with a balloon may cause severe hypotension or collapse. Any dysrhythmia, no reflow phenomenon, intervals of ischemia, reperfusion injury, or any procedural complication may be life-threatening. Then diffuse and calcified lesions. MCS is indicated in high-risk patients, LV dysfunction, especially when you are planning a rotablation. Fifth is a high-risk slow flow or no reflow, including saphenous graft. Upfront MCS is not indicated in such kind of patients, but you can use it as a bailout strategy when your slow flow no reflow is not responsive to drugs. And sixth is the hemodynamic instability during a procedure. Dr. Natarajan was describing about such a patient where patient had LAD CTO and he was doing a dominant circ, suddenly patient collapsed, and you can take a MCS in such situations. Seventh, LV dysfunction, any history of previous PCI complicated by heart failure signs or hemodynamic compromise should be considered as a warning sign for MCS even in moderate LV dysfunction. And the eighth situation is the complete revascularization, where usually requires a longer procedure time, challenging technique such as CTO or rotablation. In such situations, MCS may be considered when the patient, the procedure is complex with a severe LV dysfunction. And finally, PCA in patients with severe concomitant heart valve disease. Evidence in this field is by far inconclusive. Non-emergent MCS use in patients with severe heart valve disease is not recommended, like severe aortic stenosis, but bailout used to stabilize patients who crashed when you do this, the procedure. You can consider MCS, especially Impella, because IABP is contraindicated in severe aortic valve disease. And whatever I have talked are mainly based on the randomized trials as well as the evidence. This is a recent publication as early as May 2022 in Circulation Cardiovascular Interventions. They have analyzed, this is elective PCI with prophylactic MCS. So the importance is that 2 million patients, consecutive patients, from 2009 to 2018 were analyzed in a retrospective fashion, like observational study, but only in 0.3% patients MCS was used. What was the outcome? MACE rates were significantly reduced when you use prophylactic MCS in stable patients, but at the cost of procedure-related complications, 18.8% with MCS versus 2.3, mainly bleeding complications. So what the study adds, over the last 10 years, the use of MCS increased from 0.2% to 0.6%, mostly driven by the increase in the use of MCS other than IABP, presumably Impella, because IABP use remained low and constant, especially after the IABP Shock 2 trial. And unprotected left main PCI is the main high-risk feature for MCS use, followed by atherectomy device or LVEF less than 30%. IABP was less effective, but less bleeding complication to the IABP arm compared to the other arm. Future is for Impella. The Impella, you mean the PROTECT trials, IABP versus Impella, PROTECT 3, it was 90-day mortality, 29% less mortality MACE rate compared to IABP. The ongoing PROTECT 4 trial is Impella versus IABP. It is a 3-year result, including chronic coronary syndrome and low EF, published in 2024. And now coming to the second scenario, ACS with cardiogenic shock. Again, this is a gray area. When to start, where to start. So SKY has come with a simple classification, A, B, C, D, E. A is the at-risk patient, large area of myocardium involved, but no hypotension. And B is the beginning, patient large area, hypertension started, but no hypoperfusion. C is the classic, where there is a hypotension plus hypoperfusion, patient is in lactic acidosis, oliguria, stage D is deteriorating, your inotropes are not working, stage E is extreme stage, where patient is going for a cardiac arrest. And cardiac arrest in each stage adds to an effect modifier in each stage, complicating. And still in all these cases, MCS role is controversial, not supported by RCTs. But only guideline is MCS should be used judiciously from stage C, that is a classic stage onwards, with lactate level going up 2 millimole, hypoperfusion started, severe, and it should be done as early as possible before the onset of multiple organ injury, and requires a multidisciplinary approach with involvement of a heart team, intensivist, cardiologist, and cardiac surgeon. And types of MCS, predominantly LV failure in acute situation, you can consider IBP, Impella, tandem heart or VA ECMO, and RV failure, Impella, RP pump or tandem heart RV assist device. And finally, it is still a gray area. ACC, AHS, SKY, all guidelines for PCA provides only class 2B indication for the use of MCA in high-risk PCA. The studies published so far do not allow us to determine which MCS method is safest and most effective. The future is, seems to be for Impella. The site experience and accessibility of the method seems to matter most. Whichever you are comfortable is the best. And finally, when Ajay Kirtane was asked why MCS is used so frequently considering the dearth of evidence supporting their effectiveness, he replied, if it's a life or death situation, you are going to err on the side of supporting the patient as opposed to not. Thank you.
Thank you, Dr. Issac. A very nice introduction to the upcoming following talks on MCS types. In the end, it's obviously our experience. It's a patient in particular situation. It's the lesion anatomical and comorbidities that will determine the use of MCS. But we should not forget also about the budget, the availability of certain devices. So there are not a single trial that will be done in the future that will put this all together. So in the end, it's a decision of the operator and decision of the team, and that determines the use of particular MCS.
Yeah. Cibi, wonderful presentation. A question to Dr. Restam. Given an opportunity between an IABP or ECMO versus Impella, in a high-risk PCA, which one would you prefer? Or do you have personal preference? A less sicker patient, you would prefer an IABP, a more sicker patient, you would go in for a Impella or ECMO. What would be your preference?
Again, Dr. Davidson, thank you for the question. It depends on the particular case. For elective high-risk PCI, obviously, Impella would be more comfortable for myself and for the team and for the patient. We're not talking about long-term outcomes, we're talking about the current case in the cath lab to make the patient coming out alive with more likely complete revascularization in that particular scenario, if indicated. But yes, in Australia, like in India, it's Medicare, it's very expensive device, and it's case by case. Quite commonly, it will be no MCS, just preparation for the case, sometimes staged, experience, etc. ECMO we don't do routinely in our center. ECMO usually is done by ICU. This is something we're exploring, and this is something we will be using in the future. We're talking about some elective patients. And balloon pump, yes, sometimes we do it. Last week I did one balloon pump into the case when the patient crashed. But occasionally I do it for left main also, preemptively.
Cibi, which are the situations where you have used MCS in your lab?
Yeah, mainly distal left main bifurcation lesion, especially with LV dysfunction.
So you put it up front?
Up front, because
with LV dysfunction or the regular left main disease?
Left main, distal left main with some borderline hemodynamics. In such situation, expecting that we can use. Otherwise, when the patient crashes, we'll always take an alternate groin also prepared, and then we'll be prepared for that.
That is for the IABP, but I'm
IABP.
asking about the Impella.
Impella, the cost is a main factor
Yes,
here.
I think
That is the
it's
main.
around 18
And
lakh,
whatever they have said, prophylactic use, they don't prefer tandem heart because it requires IAS puncture, and it's kept in the left atrium. The one arm is in the left atrium, so it's a complex procedure. So
That is tandem heart, but the Impella is quite easy to
Impella
insert.
is easy to.
And I think it is kept only for 6 to 8 hours after the procedure. That's what I've heard. And then they discharge a patient afterwards.
So IAPP actually is coming down because we are using it mainly because of the cost concern, and Impella is the one which is preferred because all the PROTECT trials are favoring Impella.
And we have done quite a lot of left main bifurcations. We have never had any opportunity to use any of these support except for one crash where I had to put in a IABP.
Only when the LV is bad. LV is very bad. The LV function is very bad. The pressures are, say, 80, 60. Then you embark upon a critical lesion. Then it might be good to have an Impella.
Up front.
Up front.
Yeah.
It is also important to make sure cases like this, especially if the elective, are done by dedicated operators and dedicated teams, because experience of those teams and operators can often prevent usage of expensive MCS. Because MCS, like Impella, will not only protect the patient, but it will protect the operator, who is, let's say, moderate skills operator versus high skills. And remember that complex PCI is now subspecialty. It even comes with dedicated fellowships in the many countries. So keep it in mind, similar to structural interventions.